Hello again. Um, Earlier this afternoon, Fabrizio talked about sensory neural hearing loss and temporal bone imaging, and now I'm going to talk about the other side of hearing loss, conductive hearing loss in children. I have no disclosures. To give a background, pediatric hearing loss is diagnosed in 6 out of 1,000 children by age 18. Conductive hearing loss accounts for 90 to 95% of all childhood hearing losses. Unlike adults, because as you know in adults, sensory neural hearing loss is the most common etiology. That's why in children it's important for us to understand conductive hearing loss. Hearing is quite critical to auditory brain development, speech and language development, cognitive functions, and social activities. Therefore, early diagnosis is very critical. For that matter, newborn screening tools have been implemented, and with that, now the diagnosis for initial diagnosis has been reduced down to 2 to 3 months of age. Diagnostic workup includes genetics quite a bit at this point, and when it comes to imaging, high-resolution temporal bone CT is the first line of imaging when necessary. And this can be further complemented with MR imaging, focusing on the region of the internal auditory canals. One thing is very important to understand when it comes to hearing loss in children. Understanding the major embryological development. The outer ear, which is our pinna, the auricle, and middle ear are derived from the same embryologic origin. Therefore, if you see abnormality in one part, you should be seriously searching to see if the other part of the same origin is involved. And typically, it is the first branchial grove, first branchial pouch, and first and second branchial arches. Inner ear, however, is derived from the otocyst, and this endolymphatic system and perilymph and otic capsule are derived from the mesenchyme. A coexistence of inner ear and outer and middle ear abnormalities can be seen. However, you're more likely to find outer and middle ear abnormalities simultaneously. When we look at the etiology of hearing loss in children, approximately 50% of them are genetic. And of these 50%, 30% of them are syndromic. For this matter, genetic workup became really important in hearing loss. If we look at the etiology, we can basically break them into congenital and acquired etiologies. Amongst all, the acquired etiology, otitis media with effusion is the most common one. And as you all know, this is a typical clinical diagnosis. Sometimes these patients are referred for imaging, and at that time, it's usually not just to make the diagnosis of otitis media, but usually to look for complications such as intracranial extension, vascular thrombosis, etc. In the category of congenital, there can be structural developmental abnormalities of the external auditory canal and middle ear resulting in conductive hearing loss, or there can be congenital cholesteatomas. And in the acquired section, again, acquired cholesteatomas or traumatic injuries can be seen. Moving forward, we're going to briefly take a look at the normal temporal bone anatomy. However, in the interest of time, I won't be able to spend too much time, but I will highlight a few things. First thing first, you want to do your evaluation in a systematic fashion. You can either start from the inner ear side and go to the outer, or start from the outer side and go inwards. Because the issue is conductive hearing loss, and because it is the outer and the middle ears that is involved, I suggest if you have a patient with conductive hearing loss, start with the outer side. And here you do see the pinna, the external auditory canal, nice and patent with normal morphology. Coming inward, you see the tympanic membrane, and you start seeing the ossicles. Moving more inferiorly, you start seeing the normal orientation of the malleolus and incus. And moving further down, here you do see the typical cone, the malleolus and incus lined up like the ice cream cone. And in this region, you also see the inner ear structures, the internal auditory canal, the vestibule, the semicircular canals, and the mastoid ear cells. Mastoid ear cells are also quite important to evaluate. When we do temporal bone imaging, we typically acquire our images with 0.5 millimeter thickness in the axial plane and reconstruct the coronal images off of it. And here you do see the coronal reconstructed images of the normal temporal bone. Now, moving forward, we're going to look at each etiology and what are the common or important findings in that area. When we look at the congenital structural developmental abnormalities of the outer and middle ear structures, they're primarily divided into two categories as major and minor. This is a clinical classification. Under the category of major anomalies, there is congenital oral atresia. In these patients, obviously, there is complete absence or serious stenosis of the external auditory canal. And these can be associated with some ossicular chain anomaly. Almost all of these patients have microtia. Microtia is the term that refers to small and dysmorphic appearance of the pinna, as you can see in these two different patients. In patients with minor congenital anomalies, this is typically involving the ossicular chain, and their outer ear can be normal, their EAC can be normal, and tympanic membrane can be completely normal as well. Typically, their pinna reveal normal folds and cartilage. Congenital oral atresia can be unilateral or bilateral. Approximately 70% of the times, it is unilateral. Boys are more commonly affected than the girls, and it can be with or without microtia. It is nice to have a unilateral abnormality because you have the other normal side for your checkpoint. And here in this patient with left-sided microtia, you do see the significantly small middle ear cavity compared to the other side. And obviously, the visualized ossicle looks quite dysmorphic and perhaps adherent to the wall. Unilateral, as we said, is more common. And here is another patient. This time you do see another patient with the unilateral. And on this one, you do see the ossicular abnormality. The malleolar head is hypoplastic. The body of the incus is enlarged. And when you compare to the normal side, you can appreciate the abnormality better. Few years ago, we were interested in seeing the relationship between microtia and severity of the temporal bone anomalies. And we looked at a particular patient group, those who had persistent conductive hearing loss. Because as you know, otitis media is not a persistent cause, it recovers and gets better, so those cases were excluded. And since we're talking about similar embryological origin of development, our results were similar. If a patient had microtia, they had more severe temporal bone findings. In this graph, you can see that the microtia patients had higher levels of EHC, atresia and stenosis, ossicular chain abnormalities, middle ear cavity anomalies, and mastoid ear cell anomalies. Remember, in these patients, the mastoid pneumatization is quite limited as well, and rarely you can see some inner ear abnormalities too. Now, looking at some bilateral cases, it's important to recognize few syndromes. Treacher-Collins is a syndrome that typically presents with oral atresia. And here I am presenting a bilateral case. And you can appreciate that middle ear cavities on right and left are very, very small with a very dysmorphic looking rudimentary ossicle. External auditory canals are missing, and mastoid ear cells are not even, formed, let alone them being, aerated. The vestibule also looks somewhat dysmorphic in this patient, patulous as an additional finding. These patients typically have autosomal dominant inheritance, except for POLR1C mutation. And the most common mutation in these patients are TCOF1. About 90% of them have this genetic mutation. The other important feature of Treacher Collins is the abnormal facial development. Clearly, they have a microsomia, and the site of the abnormal development can have additional temporomandibular joint, short ramus, shallow glenoid fossa, and not even formed coronoid process. And you can clearly see the microtia, really abnormal looking pinna on each side. Another syndrome, Cornelia de Lange syndrome. These patients have very typical facial features. They do have this arch in their eyebrows. Their eyelashes are super long. There is depression at the level of the nasal bridge. And they typically have microtia. They also have brachycephaly. Again, this is an autosomal dominant inheritance, and the mutation is in NIPBL gene. They can also have additional organ anomalies. Let's take a look at the temporal bone for these patients, and here you do see absence of the external auditory canal on each side. So there is bilateral EAC atresia. Moving inward, you do start seeing the ossicles that look deformed. And then looking at the inner ear structures, the vestibules look, somewhat deformed as well. Plus, the temporal bone abnormalities, you do see the cleft palate for this patient. And when you look at the sagittal profile, micro and retrognathia is clearly seen. The tongue has a somewhat vertical orientation, and the nasopharyngeal airway is significantly compromised. When we look at the patients with conductive hearing loss, it's a good idea to have that systematic approach, look at each structure, and we can use this grading scale because it seems to be predictive of the surgical outcomes. If you see the normal presence of all of these structures as named over here, you can get a score of 10, which is the best score, and they have the best outcome. If the score is between 8 and 10, there is 80% chance of restoring the hearing to a normal level. And if the score is 5 or less out of 10, they generally do not benefit from surgery. Stapes, part of the ossicular chain, the part that has the direct relationship to the oval window, is a very important structure to clearly identify. The other important area to clearly identify is the facial nerve. Although the development is not closely associated with inner and outer ear, surgical intervention standpoint, it's very important. And here you can see the normal labyrinthine, tympanic, and the mastoid portions of the facial nerve. When you look at the ossicular chain, here you do see the incus attaching to the stapes foot plate. And it's important to see this relationship because if the stapes is absent or dysmorphic, it may require reconstruction or even prosthesis at the time of surgery. Amongst the minor congenital anomalies, those patients who have normal external auditory canal, typically, they can have ossicular chain abnormalities. This is a normal temporal bone, and you do see the normal ice cream cone, malleolus head, and the incus. And look at the incus over here. It is enlarged, and the long and short process appear hypoplastic, and malleolo-incudal joint appears fused. Again, normal side for comparison. So this typically is an issue that takes place in early gestational stage, about 6 gestational weeks, because at this time, malleolus and incus is a single mass. About 8 gestational weeks, they separate. So probably this is an event that took place by 8 gestational weeks. Another minor anomaly in the ossicular chain, fixation of the ossicles, and this is a patient that had fixation of the malleolus by a bony bar, And these are the scopy images. You can see the malleolus attached to the canal wall. After the band is cut, you can see the freed up ossicular chain and the lifted drum. This was a patient, a chronic patient in our institution, 8-year-old girl with diamond black vein anemia, status post bone marrow transplant. And patient was maintained on tacrolimus for treatment. About 4 months later, patient was admitted due to chronic otitis externa with drainage and hearing loss. And unfortunately, this was resistant to oral and topical antibiotics. In addition to their hearing loss and drainage, they also complained about a right jaw pain. Now let's look at these images. Now we're in the category of infectious inflammatory disorders. External auditory canal, the soft tissue and cartilaginous portion show a lot of soft tissue thickening and narrowing. Moving further inward, you do now see that the external auditory canal is filled and there is dehiscence of the anterior wall. Looking into the mastoid area, you do see that there is also dehiscence of the mastoid wall and there is extension into the middle cranial fossa. At this point, the concern for intracranial complications were clear and the right jaw pain was quite concerning. So what do we do next? MR imaging with contrast would be our choice. On the MR, the extension into the middle cranial fossa, we saw it by dural thickening and enhancement. And looking at the region of the right temporomandibular joint, both on the coronal, axial and the coronal images, you can see the synovial thickening and enhancement in this area. So this patient had right temporomandibular joint septic arthritis associated with their external otitis media. On the diffusion tracer image, you can see the restricted diffusion bundling up in the mastoid air cell region. So that confirmed the presence of the pus and abscess formation in that area. One of the other complications, other than what I have just described, is vascular complications because, as you know, temporal bone is very close to skull base and multiple veins and sinuses. Luckily, this patient did not have any dural venous sinus thrombosis at this time. This patient got drainage and grew invasive aspergillosis, which is typically seen in the elderly patients, usually with diabetes, and Pseudomonas aeruginosa is typically the most common one. And in this one, it turned out to be Aspergillus tereus. So this is a patient with fulminant external otitis. Moving on to the other etiology for hearing loss, cholesteatomas, which can either be congenital or acquired. These are typically well-demarcated, non-neoplastic masses, commonly described as skin in the wrong place. They are avascular, and they're not, all that common, 3 per 100,000 children annually. And the hearing loss is either due to their mass effect on the ossicles and or bony erosion from the mass. So in these patients, let's look at the congenital cholesteatomas first. These are abnormal migration of the external ear ectoderm beyond the tympanic membrane and makes up to 5% of all cholesteatomas. So majority of what you're going to see will be acquired type. Male to female ratio, it's again more common in the males, and there can be association with external auditory canal atresia. In congenital cholesteatomas, typically these patients do not have history of recurrent or chronic ear infection. It's very uncommon. And the tympanic membrane, therefore, is typically intact. And when they have a physical examination, the classic finding is a retrotympanic pearly mass. Here is a patient with congenital cholesteatoma, you do see this well-defined middle ear cavity mass. And when you look at it, you see that this soft tissue mass is primarily medial to the ossicles. And when you pay attention to the architecture of the ossicles, the malleolar head here appears eroded. Look at the normal comparison, nice, round, oval-shaped. And here you do see that the top roundness is gone. The other important thing, like we talked about, involvement of the stay-piece foot. Here in this one, again, it is involved. This is very important to notify for surgical intervention purposes. Typically, this is medial and anterior superior in the tympanic cavity. The Prusac space is usually not infiltrated. It is not a rule. It is not specific, but usually not infiltrated. Therefore, in congenital cholesteatomas, the scutum is typically sharp. However, not all of them follow the book. And here you do see another case where the middle ear cavity is filled with the cholesteatoma. Editus et antrum is filled with the cholesteatoma. There is backup of either cholesteatoma itself or backup of mucoid material in the mastoid air cells. And there is also erosion in the ossicles. So this is another patient with congenital cholesteatoma. Same patient, you can see the involvement of the Prusac space, and you can see that the scutum is no longer sharp in this patient. Acquired cholesteatoma, much more common than the congenital type. And typically, the Prusac space, pars flaccida, is involved in these patients. The typical story is these patients have chronic or recurrent infection. Therefore, their tympanic membrane is almost always perforated. They can, at the time of their initial diagnosis, their primary presentation might be a foul-smelling intermittent otorrhea. This was a 17-year-old gentleman presenting with recurrent ear infections and presenting with a ruptured tympanic membrane. And here you can see the soft tissue mass in the middle ear cavity extending into the mastoid ear cells, showing restricted diffusion, as you can see on these images. Now remember the description of cholesteatoma. This is skin in the wrong place. There's keratinaceous content, therefore it can restrict diffusion. It's an important feature to differentiate a cholesteatoma from post-surgical changes. When these patients have surgery, there can be some residual remaining, or there can be scar granulation formation. Therefore, MR imaging can be quite valuable. If you see the restricted diffusion, then the odds of residual or recurrent cholesteatoma is more likely. The differential diagnosis of cholesteatoma can involve cholesterol granulomas, paragangliomas, schwannomas, or hemangiomas of the facial nerve. However, these are exceedingly less common in children compared to adult patient population. Another etiology for conductive hearing loss, trauma. 80% of the temporal bone fractures in children are longitudinal. In the same orientation is the petrous apex. This was a young child who had a severe motor vehicle accident with polytrauma. Most of the solid organs of the abdomen were injured. Now we're going to focus on the temporal bone side of the story. When you look at the temporal bone, you can see the fracture line extending and going into the anterior wall of the left external auditory canal. And when you look at the orientation, I'm going to draw you the line of the fracture, and this is the line that represents it. You can see the fracture line in a longitudinal orientation. In these patients, when we see the temporal bone fracture, and if it goes through the mastoid air cells, we almost always see opacification. And one thing that is really important in the fracture is to look at the otic capsule and see if the cochlea and the facial nerve are preserved, which we found out in this patient that they were. So we said, wow, no ossicular chain disruption, no facial nerve injury, super, patient got lucky. But think about it a little bit more. Is he really lucky? Another important complication in these patients is, so let's see what we find out, and then we will find the answer. If you see a temporal bone fracture, pay attention to the areas where the important arteries and veins go through. Internal auditory canal, there's a little air bubble. Jugular foramen, air bubble. When you see air bubbles going into where the arteries and veins live, it may ring the bell for possibility of a vascular abnormality. Sure enough, when we did the MRI, we found out that there was dissection in the left internal carotid artery. When you compare right to left, you can see the narrowing, and you can make out the flap in the full extent of the internal carotid artery on this side, in the coronal and the axial planes. And when you take advantage of your diffusion-weighted imaging, you can see little punctate embolic infarctions secondary to their dissection. Patient had high intracranial pressures, therefore an ICP monitor was placed. That's why you do see exaggerated susceptibility artifact on this diffusion tracer image. So the first patient didn't have ossicular chain disruption. Here is another one. Again, trauma. And let's look at the orientation of the malleus and incus in this patient. You do see the nice cone, nice orientation of the malleus and the incudal body over here. But when you come to the level of the stapes and the lentiform arm of the incus, you do see that they're separated. The incus is laterally pulled, much separate than the stapes footplate. To get a better look at it, let's look at the schematic drawing. And here is the normal relationship of the lenticular process of the incus and the stapes footplate. And here is the abnormal one, the separation. This represents incudostapedial separation secondary to trauma. This is the most common form of ossicular separation. It typically happens around the area of incus because this is the bone. Due to its position, lack of muscular anchor, and weak soft tissue attachments, it gets affected the most commonly. Another form is incudomalleolar separation. This one is much easier to appreciate on imaging because we all know how the ice cream cone should look like. If you see the ice cream separate from the cone, independent of the cone, in other words, you can make the diagnosis very easily. This is incudomalleolar separation. Another cause to remember for conductive hearing loss is the swimmer's ear. I don't really know, but you guys may advise me on this one. I suspect it might be more prevalent in Brazil because you're right by the ocean, and water sports might be more, popular here. This is typically secondary to chronic exposure to water, typically cold water, and you almost always see it bilaterally in young individuals. Water and cerumen gets trapped behind the exostosis, and you do see the thickening of the bone at the level of the external auditory canal, resulting in the conductive hearing loss. It's interesting that this is typically not seen in African American patient population. In conclusion, conductive hearing loss is significantly more common in children compared to adults. It's 90 to 95% of all cases. Number one imaging modality, when necessary, is high-resolution temporal bone CT. The thorough anatomical evaluation in a systematic order is the key. And remember, most of the conductive hearing loss cases involve the outer and middle ear, which derive from the same embryologic origin. Amongst the etiologies, infectious inflammatory etiologies, such as otitis media, is the most common, however, usually diagnosed on a clinical basis and does not require imaging unless there is concern for complications. MRI can be helpful in further identification of infection involvement or differentiation of cholesteatoma from post-surgical changes, and always search for potential complications in the vascular system or extension into intracranial compartments, as temporal bone is in a very critical anatomical location. Obrigada, and if any questions, feel free to contact me anytime.